So if we can call Gemmy up now to talk about the most recent and emerging treatment in neovascular AMD.
Thank you very much, Adnan, for setting the scene. So in my section, I'm going to speak to these three objectives. First is to evaluate our treatment objectives for innovation in neovascular AMD. Second, to review recently approved treatments in neovascular AMD. And finally, to explore emerging treatments in neovascular AMD. As Arshad has pointed out earlier on, we somehow seem to be have solved maybe our need for durability. As he mentioned, in the 2023 ASRS PAT survey, you can see that greater durability in the gray bars was voted by the most participants as the greatest unmet need. How has things changed this year? At the bottom here, you can see this year's survey, and while greater durability remains important, we've seen now an appetite for the need to improve vision, and that's now overtaken greater durability as the primary unmet need. And indeed, when we're treating a complex disease like neovascular AMD, is a chronic degenerative disease. There are a lot of this discussion. We need to talk to the patient. But ultimately, our primary goal, really, I think all of us would agree, if possible, is to obtain the optimal visual acuity gains. After that, we then talk about keeping it in the long term and keeping that with as little as possible treatment burden. But really, the first and foremost is still obtaining that optimal visual acuity gain. How are we doing? I think what Adnan showed early on is really, really real, and it's good to see that. And even, in fact, in the relative recent treatment trials, we've been seeing that we learn about the mean improvement in visual acuity of, 10 letters, or more recent trials with better starting visual acuity at around 60 letters. Patients are now gaining, on average, 5 letters. But somehow that ceiling of 60-something letters in clinical trials, these are the better patients, and in Adnan's cases, 61 letters in the real world seems to be the max that we can get out of our current treatment. And in fact, as shown here, 2040 is really the important threshold that we're looking at that allows our patients to read well and to drive in most countries. And a lot of our patients are actually not reaching that important landmark. Looking more details, we see on the left-hand side some quite disappointing data, if you'd like. Despite the treatment with anti-VEGF-A therapy, almost half of the patients are not achieving significant visual gains. Remember, what we learned from clinical trials is a mean letter change, and there are proportions of patients who gain more, and there is still a significant proportion of patients who don't gain or even continue to lose. In terms of anatomy, we know that more than half of the patients actually have persistent fluid, and in fact, in recent trials, we've seen protocols that actually allow the residual fluids to be there. And finally, 25% of patients will have further vision loss at 12 months or longer. So this is talking about in the more long-term landscape. Looking at how we are doing in the past couple of years, we've seen recently approved treatments, yet their treatment goal, and we've seen the design of the treatment trials, really aim to reduce treatment burden, but do not aim to have superiority in visual gain, and the emerging therapies on the horizon are also mainly targeting increased durability. Let's have a look at a few examples. Closer to home, some of these are already available, and some will be available in the very short term. We've seen aflibercept 8 milligrams and faricimab. Both of these have demonstrated non-inferiority in visual acuity gains compared to standard of care anti-VEGF therapies, and yet majority of patients is aiming to deliver majority of patients with a longer durability on 12 or 16-week dosing. On the right-hand side, we can see that the port delivery system, very innovative new design, aims to give a constant VEGF blockade. And again, the trial design is aiming for non-inferiority in visual acuity gain with durability of refillable every 24 weeks or longer. Looking further, perhaps not quite beyond the next 3 to 5 years further down the line, of course, several trials are looking at gene therapy to produce a biofactory, but yet even more unknown with these newer innovations. Which is the best vector? We don't know, and there are possibly some unknown or lack of clarity in terms of the safety profile and what is the best way to deliver, such as intravitreal or suprachoroidal. Another area that is, again, very innovative is that to look intracellularly. And we know that a whole new class are using small molecules with tyrosine kinase inhibitors to aim to inhibit VEGF as well as PDGF. And you can see down at the bottom left, several companies have assets in this field. And yet again, unfortunately, the trials are targeting at further reducing treatment burden, but aiming really for comparable visual acuity gain to what we currently have. So none of these really address what we talked about as our top wish list, which is to provide even better visual acuity outcome. So that's why today here we're very excited to talk about the possibility of targeting VEGF-C and D, and closer in the horizon, maybe in the next year or so, is the timeline we're talking about, is sozinibercept. This is currently evaluated in combination therapy, and it can achieve broad blockade of the validated pathways in neovascular AMD, as Adnan has mentioned, blocking VEGF receptors 2 and 3. Let's look at this molecule. Sozinibercept is a fully human molecule. So in terms of our familiarity with the design of this molecule, this certainly is closer to our comfort zone. It's fully humanized, which is important. In terms of its design, it is a trap inhibitor, and we've seen this currently widely used in our clinics. A trap design, this time comprising the extracellular domains 1 to 3 of VEGF receptor 3 and the FC fragment of IgG1. The molecular weight 140 kilodalton, and really is very similar, as you know, then to what we see and have been using in the format of aflibercept 2 milligrams. It offers a potent inhibition of VEGF-C and D, and the characteristics are again very similar to aflibercept. In particular, here we have seen in animal models, this in rabbit model after a single injection of sozinibercept versus aflibercept. You can see that the profile of the ocular biodistribution and PK are very similar between these two compounds. So when used in combination, we can be quite familiar and comfortable with what we're expecting. So in summary, there continues to be great innovation, and it is really an exciting time for us continue to be in retina, in neovascular AMD development. Yet most potential new treatments have continued to focus mainly on durability and not on improving the visual outcome and trying to break that ceiling effect. On the left-hand side, we've talked about a few approaches, and really today we therefore very excited to look at sozinibercept as a potential for better visual outcomes. And in terms of the design, I've explained to you, this is something quite close to what we have used in the past. So just in summary, sozinibercept is really the only late-stage drug in development targeting superior visual acuity gain, and we'll hear some more from Annette about the clinical trial results. Thank you very much for your attention.